Dr. Colvin is an associate professor of medicine in dermatology, and he is the head of dermatology at Harborview. He runs our residency training program in dermatology at the University of Washington School of Medicine. He did his medical training and residency here in Seattle at the University of Washington. He then went to Duke to do his dermatology residency, and his area of expertise is very broad. He labels it as mostly within HIV disease in the skin, but we call him for anything on our patients. Now, this shows Dr. Colvin in an interesting environment, and I suspect he's answering emails. And he will explain this to you, in that he received a Fulbright Award to create a long-distance consulting program in Cape Town, South Africa. And he basically set up a teledermatology network where physicians could email him their questions and include photographs. And this is him again answering those many emails.
How many of you have been to see a dermatologist before? Good, a good number. Did you realize that every dermatologist is first an internist? So they're a super specialist, and they first must complete a residency training program in internal medicine before they go on to do a dermatology fellowship. So it's not just about, the emergency blemish before the prom or a rash or whatever. These are truly people that know the human body inside and out. And for a variety of we clinicians at Harborview, in the burn center, the trauma and surgery services, we turn to the dermatologists quite frequently to help us out because they really truly do know medicine inside and out. The other thing about Roy that I'm very glad that we can share with you is Roy's actually one of the finest teachers in the University of Washington School of Medicine. Roy, part of a program called the Colleges at the university that was designed 7 years ago to help better mentor our students through the 4-year process. And each year, our 30 faculty members who were chosen from among the very best teachers, among several thousand clinicians and teachers, Roy was one of those 30 chosen. So it was with kind of mixed emotions that Roy went off to do his Fulbright scholarship, which indeed was quite an honor because we lost him as one of our college faculty, but we're so glad that he's come back from doing this remarkable thing. And so we're really happy, and we want to give Dr. Colvin a real warm welcome.
Well, thanks a lot, Hugh and Joanne. It's really great to be here, and I really like talking to a general audience, and I think this is a project that lends itself well to, it's not esoteric, it's very straightforward, and I'm about straightforward. So I want to tell you basically the story of what took me to South Africa. Well, I went with my family to spend 2 years there, and what interests got me going on this. This is a satellite picture of the African continent, and before there were satellites and before there was electricity in Africa, this continent was termed the Dark Continent, probably for lots of different reasons, not because of the absence of electricity. And if you compare sort of the continent to the north, Europe, and our own continent, North America, you see that Africa truly is literally a dark continent. But it's dark in other ways too, and largely because, in this day and age, because of HIV/AIDS. This is a global distribution map of people living with HIV as of the end of last year. And you'll see that the total for the world is 33 million. But you'll see, if you look at these figures, because it's hard to kind of look at all the zeros and see what's what, that in sub-Saharan Africa, there were 2/3 of that population living there. So truly ground zero for the HIV pandemic is in sub-Saharan Africa. And it's interesting, though we first discovered the manifestations of HIV initially in Europe and North America, that the origins of this pandemic probably did really reside in Central Africa as part of sub-Saharan Africa. These are some images from popular literature. This from Time magazine in the early part of this decade, showing kind of the human face of the HIV pandemic in sub-Saharan Africa. This is a picture of a 13-year-old girl taking care of her parent who is suffering with end-stage HIV disease. And here's an image from Newsweek that shows an orphanage where the number of orphans in this area shot up because of the effect of HIV. These two articles, both that appeared in a relatively little-known journal called the Morbidity Mortality Weekly Report, showed up in the early summer of 1981. And this is really when AIDS has its birth date recorded. These are reports out of LA and New York City reporting two relatively unknown infections, pneumocystis pneumonia and a type of cancer called Kaposi sarcoma that put AIDS on the radar screen. At this time, and for a couple of years after this, this was thought to be a disease of the gay population. And so it was called the gay disease, amongst other monikers for this condition. I entered medical school in 1983, and I recall in the first year of medical school, our microbiology class, and we were questioning our infectious disease expert who was talking about this syndrome and asking, well, what's going on here? What's the cause? And it was a shrug. It was, we don't know yet. We don't understand this. And shortly after that, the manifestations of AIDS and the research that went into these individuals, not just gay men, but later on discovered to be those who had conditions that required transfusions, those that were heterosexuals were coming down with the disease as well. The international impact of this outside of Europe and North America really didn't make itself known until several years later. These are some images of Kaposi sarcoma, and many of you have probably seen the movie Philadelphia starring Tom Hanks, which wasn't until 1994 when he won an Academy Award for that. But this was the condition that he was afflicted with. I'm just going to warn you right now that dermatology isn't always pretty. In fact, it rarely is. So some of the images I have are fairly graphic, though I have to say that I pulled the most graphic ones out of this talk. So you're not seeing the worst. But these are real people with real conditions. Now you wonder why HIV and the skin have any connection at all. What is it about the skin? I mean, isn't the skin just basically an inert bag that holds the water in and holds the desert that's the rest of the world out? Well, that was the old view of what the skin really does, but we know now that the skin is a very principal immune organ. And if you think about it, I mean, all the things that are out there wanting to kill us are trying to get in either through our mouths, our noses, or our skin, and a few other places too. But the skin plays a huge immune function. And as a result of this, if you affect the immune system with a virus like HIV, upwards of 100% of patients will have a significant skin condition. In fact, the skin conditions can be prominent enough and consistent enough that you can actually stage the level of HIV disease by what skin manifestations one has. So some disorders occur throughout HIV, some get worse or atypical later on in HIV, and some only occur when your CD4 count, the cells that HIV attacks, drops below the level of 200 or lower. This is a figure that shows this graphically. You'll see conditions which some of you may be afflicted with, and it's part of normal population, but they become more prominent in HIV infection. Here's early on in the infection where your CD4 count is normal prior to. It takes a quick drop when you get an acute infection, comes back to near normal, and then starts to slowly drop over time. And as someone becomes more symptomatic with HIV, these conditions, and a lot of other ones, become much more prominent. Shingles or herpes zoster, seborrheic dermatitis, which we commonly know as dandruff, and a lot of other conditions become worse as one advances with their HIV disease. So HIV dermatology is interesting. I got interested in this as I was sort of growing up with the HIV pandemic, and then turned to dermatology training and realized the pandemic was still there and there were a lot of patients afflicted with things. I would have expected if you lowered someone's immune system that they would be afflicted with a lot of unusual infections. In fact, that was kind of the interesting part to it that I was looking towards. But when I got into it, I found that many of the skin conditions are actually non-infectious and inflammatory, which doesn't make a lot of sense when you look at it superficially. When you compare people with HIV to those who, say, have an organ transplant and are on immune suppressives as drugs, those patients get a lot of interesting and unusual and bad infections. Whereas HIV patients get some of those things, but they get a lot of other things like eczema and psoriasis and things you don't think about as part of an immune suppressive disease. And we may touch on that a little bit as later on in this talk. We sometimes recognize HIV disease first through a skin condition. And a lot of skin conditions, fortunately, have been helped greatly by antiretroviral medicines, particularly since 1996. When I started here on faculty that year, was the same year that protease inhibitors, one of the most prominent antiretrovirals nowadays, came on the scene. And I had 3 sessions of HIV dermatology, not just general dermatology, just HIV. And then by the time I left for South Africa in 2004, I had 1 half-day session, and I really didn't need that because most of the patients were on highly active antiretroviral therapy and were doing well, and they had basically the same conditions that the general population had. The flip side of that is that sometimes antiretrovirals can bring on skin conditions. This is a school teacher who I saw in Cape Town who came with no other complaint than this swollen index finger on the left hand. And this patient, we had all kinds of ideas but didn't really know exactly. So what we did was took a biopsy, which is very easy to do for skin conditions. So we took a biopsy here, and it turned out that this was Kaposi sarcoma, which really, astounded all of us there. And I was around doctors who saw Kaposi sarcoma every day. And this was the first manifestation that this patient had of his HIV disease. He had no weight loss, no other conditions, but he had KS, and he turned out to be HIV positive. So we unearthed his HIV infection from this condition. Now, in sub-Saharan Africa, skin disease is very prominent and was prominent before HIV hit in the 1980s. And there are a lot of patients with skin disease and very few skin specialists. In South Africa, where I was, in the public sector, where most of the population with HIV gets their health care, there are about 3 to 4 million people per dermatologist. There are only 11 dermatologists in the country that are serving in the public health sector. So if you can imagine a practice with 3 to 4 million people, somewhat overwhelming. So obviously, a lot of people aren't getting seen by a skin specialist. And partly because a lot of those patients are in rural areas, they have limited funds to get to a center where there is a dermatologist. And so these patients are trying to do the best they can with what resources they have, and the docs and nurses that treat them are trying to do the best they can with what limited resources they have. And as a result, these patients are getting a lot of empirical therapy. They have 3 creams on the shelf. They take a guess as to what this rash could be, and they try one, and if it works, great, and if it doesn't, well, then that's a waste of resource, unfortunately. And because HIV prevalence is so high, anywhere from 15% in sub-Saharan Africa up to some pockets that are 60%, HIV skin disease is very prevalent there, and it's complicated. And why is it complicated? Well, in someone with HIV, you can see more than one skin condition at a time. And often the common things present uncommonly. And as a result, the conditions are hard to recognize. And even though you may recognize them, diagnose them accurately, they can still be tough to treat because the immune system is not contributing to the patient getting better. In fact, it's working against one. So these conditions can be recalcitrant, and it causes a lot of confusion for non-dermatologists. This is a patient who has a skin condition involving his mucous membranes and also generally as a result of one of his HIV medications. This is a patient who had recently diagnosed HIV infection. We know it's advanced because this is, again, Kaposi sarcoma. This is a patient who has a generalized rash, which looks like about 10 or 20 different things that I could think of. This would require a biopsy and a culture to diagnose. It's a relatively rare disseminated fungal infection called sporotrichosis. This is a patient who didn't know she had syphilis, which we diagnosed from this skin rash, but she also didn't know she had HIV, which we also diagnosed as a result of this skin rash. And this is a patient who has, again, another systemic fungal infection manifesting in the skin. These are some of the not-so-pretty pictures of HIV skin disease that I encountered in sub-Saharan Africa. So how do we relieve this burden of skin disease? Well, one logical explanation is just train more dermatologists. It's easy enough. You've got a supply problem, and you've got too much demand, so let's increase the supply. Well, that would be nice, except it's very costly to train anyone in a medical specialty in any country, and even more so, relatively speaking, in a place that has poor resources. And the other thing is, once someone becomes trained in a medical specialty, it doesn't hold them there. There's no guarantee that person's going to practice in their community or in a remote community where it may be necessary. In fact, many people who get trained as dermatologists in sub-Saharan Africa leave the region and go work in the UK or in Europe. Why not? I mean, really, for them, on a personal level, they can do much better, they can have a higher standard of living. I can't blame them, really. You can train non-dermatologists and make them skincare specialists, and that's been done with nurses and the equivalent of physician's assistants in certain areas of sub-Saharan Africa. You can enhance training in general medicine and in medical school there. And then one idea that I came up with, certainly wasn't the first, is that you could actually extend one's expertise through virtual consultation. So although healthcare is maybe a limited resource in sub-Saharan Africa, information and communication technology, interestingly, is doing fairly well and getting even better as time goes on. This data is from the CIA World Factbook, which seems like an oxymoron to me, but actually is a pretty good resource. Internet use in South Africa, for example, ranks 36th in the world. Is cell phone use 20th in the world, and landlines 36th, and that's despite a GDP per capita of 76. So despite the limited income one may have, they're doing pretty well electronically. I actually learned to use a cell phone in South Africa. I really didn't know how to text message, for example, until I got to South Africa. I had to have someone there teach me. And in Africa, just comparing South Africa to the African continent and other continents, internet penetration, or the percentage of internet users per population, South Africa is doing pretty well. It's ranking up there with Asia. It's nowhere near North America, which is 70% and growing. And it's not quite the world average, but it's doing fairly well. And within Africa, South Africa, Egypt, Nigeria, Morocco, the four most populous countries, well, four of the more populous countries have pretty good internet penetration, although there are populous countries such as the Democratic Republic of Congo, which has a very small percentage of internet users. So is there some way that you could use the assets, the relative assets in information and communication technology, and boost shortfalls in healthcare? And that was a question that I went to South Africa asking, and this came out of some experience I'd had using something called telemedicine. And telemedicine really is nothing more than practicing medicine across a distance, usually with some kind of electronic communication device. For example, when Hugh Foy picks up the phone and calls me to describe a rash in one of his patients, that's a form of telemedicine. Of course, I'm going to tell Hugh Hugh, this is dermatology, it's a visual specialty. I really can't understand what you're seeing because you're describing things with words. I really need to see pictures, okay? And telemedicine really lends itself well to visual specialties, and dermatology, as you can already see, is a very visual specialty. Pathology is another one. Radiology is a great example where telemedicine can be used and is used in this country and others. In telemedicine, there are two primary modalities. One is live interactive video conferencing, just like it sounds. You get some specialists together, you get them in front of a camera, you have images projected in real time to them from a remote site. And it works, when it works very well. The problem is that the equipment's pretty expensive. You have to get people together at the same time, so logistically it's not very convenient. I attended this session at the University of KwaZulu-Natal in Durban, South Africa. And it's clunky. You have to have a session set aside so that you can do this, and you have to have the doctor at the other end who's sending you the signal with the patient there at the same time. So it's not convenient for everyone. The other modality is called store and forward, and this is just simply taking a still image of someone, transferring it by whatever means, it could be by cell phone, it could be over the internet, to a receiver at the other end. Now it's stored on my email or on my cell phone, and I can pick it up whenever it suits me, when it's convenient for me. And through that same line of communication, either through email or through cell phone texting if I want to, I can send my opinion back. Now the nice thing about this, and you can see why I'm biased in favor of this, is that the equipment is very cheap. Most of you here probably own a digital camera, probably better than the digital cameras I was using in South Africa. And it requires, logistically, it's not complicated at all. You just have to have someone at the other end send you pictures of the patient. The patient can go home and come back, or if it's necessary and it's urgent, I can see those images within a frame of time that the patient can wait. And then I'll look at the images and send back an email or some kind of opinion back by the same means. So a lot of ways this works well in a resource-poor place, and one where there's low bandwidth. So when I went to, or before I went to South Africa, I came up with a protocol where my goal was to extend and enhance delivery of skincare to underserved areas of South Africa using store and forward technology. And before I go too much further, I have to acknowledge certain people and certain organizations, because if it weren't for these people and organizations, none of this would have happened. The first is a mentor of mine at Duke, Neil Prose, who actually sort of turned me towards South Africa because I wasn't really thinking in that direction. I thought South Africa really was too advanced for me to really do the kind of work or to do the kind of thing I wanted to do in sub-Saharan Africa. Gail Todd is the head of the dermatology department at the University of Cape Town, and she was enthusiastic about having me work with her. And if it weren't for the Fulbright Commission and our regional Puget Sound Partners for Global Health and the American Academy of Dermatology and the second year, the University of Cape Town, who funded my time there, I couldn't have done it. And lastly, I couldn't have done it without support from this institution, namely my division head, John Olerud, and my colleagues at Harborview, Phil Kirby and Marshall Welch. There are always people behind you. I should also mention my family, my wife and my kids too, two of whom are here in the audience. So what I did here was to identify committed dermatologically underserved healthcare sites. They had to have email, which wasn't a problem because the provincial healthcare system in South Africa was email enabled. I made sure they had digital imaging equipment, and what I did for that is I went to a shop in downtown Cape Town and off the shelf bought a 4-megapixel camera. It wasn't top of the line then. In fact, now you can't even find a 4-megapixel camera, but it was a reasonable cost and it was enough resolution for this project. I then took a camera to the sites that we identified and taught them a little bit about digital photography. Most of them already knew. And then we began to receive referrals. This was about 3 months after I had arrived in Cape Town. And my goal was to get an opinion back within 5 to 7 days, sooner if I could. And sometimes we did it within an hour if it was an urgent situation. I would get a cell phone call from my colleague from the sending site and say, look, I've got someone who's in a bad way, could you look now? And I would go to my email, look at the images, and over the phone I could give advice right then and there. So it was telemedicine almost in real time. And then my goal was to provide feedback to the referring provider and any educational resources. And then, of course, we collected sort of quality assurance data to make sure everyone was happy, including the patients. And then I would revisit the sites at a later time to see how things were going and to actually do some teaching around the cases that they had sent to me. So the best way to really see how this system works is just to give you a couple of example referrals. And I think these will be illustrative. So here's a woman, and I'm showing you the pictures first as opposed to the history. We do things a little bit backwards in dermatology where it's important for us to look at a patient to get our own ideas about what's going on before we hear any biasing information from the patient or the provider. I know that sounds like we don't trust people, but the skin never lies to us. So here's a woman who has bumps, we call them papules, on the forehead. They're a little bit hyperpigmented. They look like they're itchy to me because I see some areas where it looks like the skin has been scratched. They're behind her ears, on her upper back, upper chest. And already from when I looked at this a few years ago, I already knew what this patient had from the images. The history just helped confirm things for me. And this is basically verbatim what the history was as it was given to me, and you don't need to read it all, but this is from the provider who tells me that this patient has known advanced HIV disease, is on antiretrovirals, and there's the regimen. Also is taking Bactrim, a common antibiotic used for preventing infections. And this rash occurred 3 weeks after commencing her HIV medicines. And he's worried that this is a sensitivity to one of the drugs, one of the antiretrovirals. And you know, that is a concern. You start a new medication, a few weeks later you develop a rash, you think it's an allergic reaction to the medication. And so his thought was, I better stop her HIV medications and think about something else. Well, for me, I recognized that this was a condition called eosinophilic folliculitis, and not something I would expect any of you to know about, because this is not a common condition outside of the HIV population. And this is a fairly common manifestation when one's immune system is reconstituting after starting antiretrovirals. So the last thing you want to do is to, slow the ball down when someone's immune system's kind of coming back. You don't want to stop antiretrovirals. You actually would just continue and treat the condition symptomatically so that until it gets better, and it will over time. So this is a situation where one's immune system goes out of balance initially with antiretrovirals, and then when time will come back in balance, and this condition will go away. So don't stop medications, continue. And that was the recommendation I gave. And with that, I could say, this is not just my idea. Here's a paper from the literature that I could get from HealthLinks, which is a resource that I use here at the University of Washington all the time. I sent the full PDF article talking about this condition to that provider, and he could read it if he wanted to. We did that in the span of about 2 or 3 days to get that information back to the provider. Here's another referral, a short history, 32-year-old, no history of HIV in this situation, otherwise healthy. And she has these lumps under the skin with some pigment change and some scarring. They're occurring on both arms. This area here is actually a vaccination scar, but the real disease is here. And in this situation, I couldn't tell exactly what it was. I had ideas, but I wasn't absolutely sure. And I needed more information. And so what I needed was a biopsy. Now, I don't have, perhaps I could with some of the things that have been going on with simulation and surgery that you may have heard some of, but I can't do a robotic biopsy, at least with the way things are. But at least what I can do is on the same image that was sent to me, I can indicate where I want a biopsy done. And I said, and this was actually sent by a nurse who wouldn't be doing the biopsy, said, get to your any GP or surgeon that you're working with, and she worked in a provincial hospital, so that wasn't a problem. And I want you to do a biopsy here. I want to make sure it's deep, and I want to make sure that you get subcutaneous fat, because that's part of the diagnosis here. And she did exactly what I asked her to do, sent that to a national lab where the pathology was read, and sent me back a result, and then I could interpret what was going on here very clearly and put the patient on specific therapy. So here was a kind of a bounce back and forth way of communicating until we got to the right diagnosis. This is what the network looks like. It is hubbed in Cape Town and reaches out to the Western Cape Province and all the way up to the northeast part of the country called the Limpopo Province, which is up near the border of Mozambique and Zimbabwe. These are the more remote sites. One of these sites was an antiretroviral clinic run by a private general practitioner. We're actually international now because we have a site in Maseru, Lesotho, which is a country independently of South Africa that is sort of entrapped by South Africa. Our results, at least during the time that I was there, because now I've handed it over to the dermatologist in Cape Town to run, is that we had 161 referrals from 7 sites over about a year and a half's time. They were from 11 different providers, 2 nurses included in that. And the mean time of reply was 3.4 days. That included my weekends, the time my family and I took trips to go see wild animals, that sort of thing. So 3.5 days to get seen by a dermatologist and get an opinion back. Now those of you that raised your hand earlier about seeing dermatologists, probably the time of referral that your primary provider, that time when that person sent you to a dermatologist or you went seeking a dermatologist and the time you actually got in to see a dermatologist was not 3.5 days. I'm pretty sure of that. In fact, at Harborview, our wait time for a new patient is about 3 to 4 months. So for a patient in a remote part of South Africa to get seen by me and get an opinion back with or without an attached reference, which never happens in real life. You never get your consultant sending you back an article based on that never happens. Even in academia, it never happens. In 3.5 days, it's pretty good service, and it wasn't that hard. I was just me doing that. So if you had a number of people doing that, it would work out. The interesting thing, and this is work that I did with a medical student here named Mia Shim, who looked at my data and saw that if you look at the referring providers and what their clinical opinion of what their patients had were at the beginning of the use of the telemedicine system, and then later on in the use of the telemedicine system, their concordance, in other words, the agreement between my opinion and their initial opinion went up dramatically. Here, in the first through the 4th consultations that they sent, the agreement was around 10 to 15%, which is expected. I don't expect them to know a lot of dermatology, and that's why they're referring them. But as they used the system more, up to between the 9th and the 12th referral, their concordance with my opinion went up to close to 50%, which I think is a very steep learning curve here. And I think it's probably the most substantial, sustainable effect of this network is that we're actually not making a huge dent in the skin disease ourselves by seeing the patients, but we're training people to become better skincare specialists. And that's, I think, the beauty of this thing. So the tangible benefits of this system were that there was a specialist opinion available where it wasn't before, that it was timely, that you could print the referrals and put them in the medical record, and you had archived images. If the patient returned to you with a different look to their condition and you wanted to compare, you could do a side-by-side comparison. There was an opportunity for the provider to learn, both in terms of references, etc. And there was further education when I went back to visit the sites with just one-to-one case review. We reviewed photographic technique if there were problems. We did case conferences like a grand round situations in the provincial hospitals, and then just my one-to-one feedback with each opinion that I sent. We also, while I was there, we had an exchange going between the dermatology training program in Cape Town and the one here, where we were sending images of things that they don't see much of here from Cape Town and vice versa. In fact, they don't see a lot of skin cancer in their dermatology training program in South Africa because largely the population is dark skin. And so for those residents to get training in skin cancer, they'd have to go into the private sector to where more of the white population is being seen with skin cancers. So it was a very fruitful exchange. The lessons I learned through this system is that, one, telemedicine is about people and not about gadgets and technology. You have to have the right person at the other end to get on board with this. If you don't, it's not gonna work. And the simpler, the better. In fact, the cheaper, the better. Cheap equipment, it works very well in this situation. You also can't impose telemedicine. You can't go to a site and say, this is mandated, you need to do this now. That happened in England, and it flopped. Telemedicine has not taken hold in England because it was mandated from the National Health Service, and it's not working well. So it must come from the providers. The demand must come from the providers. And then the real sustained benefit, as I mentioned earlier, was that you're training non-dermatologists to be better skincare specialists through a case-based, on-the-ground, relevant system. Now, I went into academic medicine partly because I would never have to use these three words, return on investment. I've never been a business type, but in terms of return on investment for myself and for this institution on my 2 years in South Africa, I haven't stopped doing telemedicine. Even though I've handed over the program to my colleagues in Cape Town, I'm still very active in telemedicine in this region. And since I've been back, which has been about a year and a half, I've been involved with basically bringing the same system from South Africa and using it in rural parts of Western Washington in collaboration with the Western Rural Healthcare Collaborative. I've worked with Deidre Buchwald and Cara Towell working on the Native People for Cancer Control telehealth project. I'm setting up a system with Nancy Sugg and colleagues at the Pioneer Square Neighborhood Health Clinic doing triage for our most indigent population in Seattle. And I'm still working internationally with a group called the International Training and Education Center on HIV, or ITEC, which is under the umbrella of the Global Health Department. This is their website. And recently, people asked me, when are you going back to Africa? And I've been back once for a meeting. I'd love to go back, whenever I could afford to or had a good reason to, or if someone would pay my way to. But I've been back to other sites in Africa via ITEC with something we call virtual office hours, where we have in real time a forum for these sites to send us cases that are of difficulty for them, so that we can have a real-time patient case conference talking about their patients. And what you see here is me, that's just a still image, and below that is texting from all the various sites, including Kenya, including Ethiopia, including Namibia, from providers there that have a lot of knowledge about dermatology, even though they may not know the specific of the one patient that they're sending. So that's working very well. The other thing, which was the beauty for me, was taking myself and my family there. This is my daughter, who then was age 9, who now is sitting up here at age 12, a lot taller than this. This is Camps Bay, just outside of downtown Cape Town. That's Lion's Head behind her. But what was really wonderful about this trip was taking myself and particularly my children and wife, out of mainstream American culture and exposing them to South Africa, because there were a lot of things to learn there and a lot of beauty to be seen and a lot of interesting people to meet, and a lot of history in South Africa, which didn't go unnoticed by us. This is the entrance to Robben Island, where Nelson Mandela spent 18 or so years. This is his prison cell. This is his view from his prison cell. And we got to visit townships that surrounded Cape Town. This is my wife. My son is the one with the glasses on. In addition, we got to see some of the amazing wildlife in southern Africa. This is from the northern part of South Africa. This is from Namibia, the red sand dunes there. And this is a sunset over African skies. I appreciate your attention for this talk. Thank you.
This program really gives you all the tools that you're going to need to prepare for medical school. It challenges you academically and personally to become a better student and a better future physician.
Getting in the field of dentistry is more just a dream. Now I actually feel like I'm in the pipeline.
They're talking about radiology, surgery, pediatrics, and all these different areas of medicine that I hadn't heard of before.
I was not sure whether to go dental or med, and just coming here and being able to be in an OR in the hospital, being with doctors, the exposure, and opening myself to different experiences has helped me decide what I want to do.
The SMDP, it stands for the Summer Medical Dental Education Program. And what it is, it's a 6-week summer enrichment program that invites college undergraduates to spend that 6 week with us in order to prepare themselves to be more competitive for either medical school or for dental school.
It's a program that we administer on 12 sites across the country. There are 80 participants in each site. 9 of the sites are combined medical dental sites. 3 of the sites are medical only sites. And the goal of the program is to bring the best students that we can from across the country who are interested in pursuing careers in medicine and dentistry, who are largely from groups underrepresented or disadvantaged.
I'm from a family of 15 children. I'm the 9th. My parents came from Mexico, and I was born here in Toppenish. I worked in the fields since I was about 4 with my parents. I only worked there like 3 or 4 years. In elementary, I did really well, but it was middle school that really challenged me. Because in elementary, there was bilingual teachers, and in middle school there was no bilingual teachers because my first language is Spanish. Once I went to high school, it was much better. College, again, was really tough. It was like a big jump there from high school to college for me.
And there's emerging research that's coming out.
Going away from my family, when I had to come here, I hardly get to see them because I'm very close to my dad. I'm the first one to come to university, the first one to go into medicine.
I grew up in Lancaster, California. It's a suburb of Los Angeles. I'm 22 years old. That's because I took some time off to go to the Marine Corps and serve my country. I continue to serve the military to this day as a reservist. My goals are to get a DDS and become a dentist so that way I can go and help the underserved communities. Though I had done well in high school, I went to college with the wrong mentality, but after coming here, they taught me the study habits and what have you, what's necessary to elevate yourself to the next level in the hard sciences.
Look from back here.
I want to go back and help the urban youth who can relate to me. That's why I try to keep my slang and not try to become too acclimated.
I grew up on the Acoma Reservation. Growing up on the reservation is really close-knit, and I had to make the decision to leave the reservation to get higher education in Massachusetts, and I really feel that really helped me because I was able to know, the disparities on the reservation, and that acts as a motivation when I'm in college. When I do get homesick, I think, I want to help my family, and my family includes, the other community members of Acoma and Jemez and just Native American people.
My name is Karina Chavez. I go to UC Berkeley. Currently, I will be taking organic chemistry. I have 4 more classes to take in the sciences. I'm a psych major, so I really enjoy psychology. I'm planning on going to dental school, hopefully in 3 years.
I'm half black, quarter Mexican, quarter white. Really proud of all my cultures. My mom raised me and my sister. I watched her go from welfare to a full-time job, and then she went into nursing school. We didn't have a lot of money. Grew up on commodities and cheap food, but my mom always made sure there's food on the table, milk in the fridge, And she never let us know that we were at a disadvantage. We were always happy. She always made sure that we were able to do things and pursue them.
I had pretty much come to the decision that I wanted to go into medicine, and then in my junior year I applied to the program and I came and I stayed here in Seattle for 5 weeks, and I was just afforded some opportunities to observe surgeries and see trauma, and just that was just amazing for me because it was just like full immersion into medicine, and it was just full on and just amazing, and definitely cemented my decision to pursue medicine.
The double bond actually splits up into 2 bonds.
Students are exposed to an array of science and math courses that emphasize oral communication skills, writing skills, and it's all designed to bring them to the door of medicine and dentistry, better perhaps prepared than they otherwise would have been, but certainly with confidence that they can achieve admittance to medical and dental school.
Remember, everybody's face is different.
I'd compare this program to boot camp. It's actually an academic boot camp. It's the same thing that I did in the Marines, except for now it's academic. Instead of running and push-ups, I'm reading and studying, writing papers and reviewing my physics and chemistry. From 8 a.m. till 5 p.m., it's just academic grind.
Yeah, no pressure. No pressure. It's hard sometimes to push yourself and really reach those higher levels of potential that we have. What these programs do is really push us to that, and then we kind of see ourselves that we won't break and we won't fall apart, and that we actually do gain a lot from it.
Oh, I get it. You just go back around. It's a full schedule. It's a little overwhelming on first, but you learn how to balance things, and I think I'm pretty good at it.
I really like it so far. It's like training for a marathon before I go back to school. I've really learned a lot from taking physics courses to the organic chemistry to writing and composition.
Now, at this point in time, how do you manage stress in your life?
The classroom stuff to me is just, it's wonderful. I love to hear about coping with the stress, about, every class that they have just sucks me in, and I just want to learn and learn and learn.
The nightly tutoring sessions were optional for those who need the extra help, and because of the intense scheduling, a lot of students do need the extra help.
The tutoring is wonderful. It wasn't until I came here that I realized that you can actually ask people for help, and there are people willing to help you get there.
Apart from the academics enrichment, they do have the hands-on experiences here and their first-time experiences. So suture clinic for one thing, where they're sewing up pigs' feet, and then they'll probably later do that in their medical school and dental school training.
I'm going to go ahead and enter the patient's right-hand side.
We also have some patient intubation simulations. Our students are in there playing with mannequins, learning how to intubate a person.
It works. We just saved his life.
Though they won't practice this on a real person, they do get the first hands-on experience.
Being here and just being in a class where everyone's a minority in some way or form, it's just great. You just feel at home, and everyone respects each other, and this program has really helped me as a person.
It's great that a program like this exists. I mean, where else do they fly you out here and pay for your food, pay for your room and board, and give you a stipend, and all you have to do is read books? You're getting paid to better yourself. Can't beat it.
Well, let's see. I've got a hernia procedure, an exploratory lap.
The enthusiasm that you see in their faces when they come back from witnessing a simple surgery is quite dramatic, and something that I think that they will truly remember.
Each student has the ability to visit the Harborview Emergency Room or the UW Medical Center operating room, or even go up to Mount Vernon to visit the microcamps.
And these particular camps are for a lot of the migrant farm workers that are in our local area for a very temporary period of time. And we offer them blood pressure screenings, diabetes screenings as well. And we also do tuberculosis skin testing on them as well.
I could not imagine the magnitude of poverty that I saw there. The living conditions were just, they were chicken coops and people lived in them. When I went there and I was with those kids, it made me look around and I go, you know what, this is the reason why I'm going to medicine. These kids and their lives, that's my drive. This is why I'm here, and this is why I'm going to be a pediatrician. So it's really helped me cement my reasons for going into medicine.
I found doctors from this program who have been able to help out their communities, go back home, and help the underserved, and I think that's great to be able to give back to society.
I have a great mentor. He's a radiologist.
We use magnifying glasses if we need to.
He shows me and he explains to me what he's doing.
Take a look at this. Do you see anything that kind of pops out at you as being abnormal?
When I see an x-ray of breast, I actually know what we're looking for. He recommends treatments for what he finds, so I kind of know a little bit of that. The mentoring's great.
Keep an open mind. Don't focus in on one thing too early. You're going to have a lot of fun in medical school deciding what you want to do.
Well, back home, there's a lot of Hispanic people that work in the fields that don't really like to go to the hospitals or the clinic, and I'd like to change that.
You don't realize that a DDS is actually a doctor of dental surgery until you have the opportunity to shadow dentists, and dentists are doing surgery every day. The mentors are great. They let you get real close and see everything that's going on.
It's given me so much more confidence. I mean, the road to medical school and stuff, it's challenging, and for every negative thought I had, there was always more people in the program there to tell me that, hey, you can do this, you know, to support me, encourage me, and that's just really helped me tremendously.
It's a program that allows them to explore their options, and we're about trying to help students become good citizens and to select a career that will make them happy and that will allow them to make a contribution. We hope it's in medicine and dentistry, but if not, we just hope that we've helped them along the way to making a decision that will best suit their needs.
This is what a student needs to do, get experience one-on-one and see for themselves, and just being there really helps decide if that's what you really want to do.
Follow your dreams. If it's going into medicine or going to any kind of teaching or anything that calls to you, especially if it's calling you to help your people.
It's helping me get an overview of the courses I have to take to get into med school. It's like a little spark that's going to keep me going. Now I definitely know I want to go into medicine.
I love this program. It's the best thing I've ever done.
But if you have any interest in medicine, I would definitely recommend that you apply, do it as early as possible, and come and be prepared to experience an amazing, amazing time.